In a high-volume primary care clinic, the daily intake is a rush of visible, immediate complaints. Yet, amidst this triage of urgent symptoms, one of the most common and destructive medical conditions routinely slips past well-meaning providers: alcohol use disorder. This systemic oversight happens because alcohol use disorder rarely presents directly. It hides behind a phenomenon known as somatic masking. Patients rarely arrive requesting addiction intervention. Instead, they schedule appointments for treatment-resistant insomnia, stubborn hypertension, or gastrointestinal distress. Psychiatric complaints layer over these ailments. Patients describe generalized anxiety or persistent low mood, further burying the root cause. Providers follow standard protocols, deploying limited time and resources to treat downstream symptoms as isolated problems. Prescribing a sleep aid or adjusting blood pressure medication does nothing to halt the physiological damage of chronic alcohol use. The clinical failure continues. Detecting the disorder requires a method to systematically strip away these clinical decoys. This blind spot is an architectural flaw in how intakes are conducted. Relying purely on presenting symptoms without a systemic root cause detection workflow ensures the core pathology remains invisible. Moving past presenting complaints requires a standardized clinical filter. A patient comes in with anxiety, receives a prescription targeted only at that symptom, and the intervention inevitably fails because the underlying alcohol consumption continues to destabilize their neurochemistry. Breaking this cycle requires implementing brief, validated screening tools at the very beginning of the routine intake process. In primary care, the premier instrument for this task is the Audit C. Instead of asking for a patient's subjective opinion about their drinking habits, this tool measures specific, quantifiable consumption patterns. By asking about frequency and volume in a non-judgmental, standardized format, the Audit C dissolves the somatic mask and exposes the underlying disorder. A positive screen is a clear directive. It shifts the provider away from general diagnostic guesswork and triggers a specialized medical evaluation. Systemic screening is the non-negotiable first step. Without it, the data required for accurate clinical staging remains out of reach. For decades, popular culture has framed heavy drinking as a failure of willpower or a flaw in character. Those frameworks are clinically useless. Alcohol use disorder is a neurobiological condition. Like any disease, it must be properly quantified to be treated. The medical standard for operationalizing and staging this condition is the DSM-5, which uses 11 distinct criteria. We can group these criteria into clusters. The first cluster measures loss of control. This includes drinking larger amounts than intended, making repeated, unsuccessful attempts to quit, and experiencing intense cravings. The second cluster tracks physical adaptations in the brain and body. These are the twin physiological markers of tolerance, needing more alcohol to achieve the same effect, and withdrawal symptoms when alcohol leaves the system. The third cluster evaluates functional impairment. This means the patient continues to consume alcohol despite clear, documented harm to their health, career, or relationships. These 11 criteria do not act as a binary checklist. They form a cumulative spectrum that dictates the exact level of required intervention. Presenting with just 2 to 3 of these criteria meets the threshold for a diagnosis of mild alcohol use disorder. 4 to 5 criteria escalate the diagnosis to moderate. And presenting with 6 or more criteria pushes the needle into the red, severe AUD. Plying a patient's symptoms on this exact DSM-5 scale elevates the provider's response from offering general advice to deploying targeted, medical-grade therapy. Historically, moderate to severe cases of AUD have proven highly resistant to single-method approaches. Talk therapy alone or medication alone frequently falls short. Beating the disorder requires building a multimodal, concurrent treatment architecture. The left pillar of this structure is psychosocial care. This involves structured, evidence-based methodologies like cognitive behavioral therapy to identify triggers, and motivational interviewing to build the patient's internal drive to change their behavior. The right pillar is pharmacotherapy. Providers can utilize FDA-approved medications like naltrexone, acamprosate, and disulfiram to actively alter the patient's neurochemistry and suppress cravings. But even with both pillars in place, the structure will collapse if it does not concurrently address co-occurring psychiatric conditions. Attempting to treat the addiction while ignoring underlying trauma, severe anxiety, or depression practically guarantees a relapse. Durable recovery is an engineered outcome. It requires these two pillars supporting the total, integrated psychiatric health of the patient. Even the most rigorous clinical models fail if the patient cannot actually sit in front of a qualified provider. In practice, geographic isolation and the persistent stigma of walking into an addiction clinic are massive barriers to this dual-pillar architecture. The systemic solution is to route care directly to the patient through a fully HIPAA-compliant telehealth infrastructure. Coping and Healing Counseling, or CHC, was built to execute this exact clinical model in the real world. Operating across all 159 counties in Georgia, CHC bypasses local provider shortages entirely. To staff the psychosocial pillar, they deploy a culturally competent team of over 15 licensed clinical social workers, professional counselors, and marriage and family therapists. When DSM-5 staging indicates medication, CHC provides integrated prescriber referrals, securing the pharmacotherapy pillar. To remove financial barriers, Medicaid fully covers sessions with a $0 copay, and commercial plans cap costs at $10 to $40. Unmasking alcohol use disorder in the primary care clinic is only the first step. Routing those patients directly into accessible, compassionate, and evidence-based care is the core mechanism that ultimately saves lives.